I am honored to introduce you to today's exceptional speakers. We have, first of all, Dr. Don Dizon, a medical oncologist who is a professor of medicine and surgery at Brown University, director of pelvic malignancies and lifespan cancer center institute, and the head of community outreach and engagement at the Legaretta Cancer Center at Brown University in Providence, Rhode Island. Joining Dr. Dizon is Blakely Schmidt-Anderson. She is a patient advocate who was diagnosed also in 2019 with early stage breast cancer. Blakely is a patient of Dr. Dizon, and both of their bios are also on lbbc.org. Welcome, Blakely and Dr. Dizon, and thank you so much for joining us today.
Thank you for having me.
Thank you for having us.
Dr. Dizon, I'd like to start off with you first, just to give us, if you would please, a little bit of context for our conversation. So I'd like to start by having you give us an explanation of personalized medicine and standard of care and what that really means.
Right. This is, it's a concept that's been with us now for at least 8 years, even 10 years. But it's the notion that cancer is not just this one monolithic disease, and that even breast cancer isn't one disease that requires a cookbook recipe to treat. We know that breast cancers come in different forms, and the ones that people have most likely heard about: hormone receptor positive disease, triple positive disease, which is hormone receptor positive, HER2 positive, triple negative disease, which is negative for hormone receptors and does not express the HER2 protein. And then there's ER negative, HER2 positive disease. Right? And all of these 4 very basic forms of breast cancer require their own treatments. But even now, we're learning that within each of those 4 groups, there are little subgroups that may require even more diving deeper to figure out what the tumor is. And that if you just focus, say, on hormone receptor positive disease, people are now getting tested for what's called the recurrence score, or they may be going through an assay that will indicate, based on the tumor DNA, what are the chances that it could come back. In fact, they may get a prognostic score of, say, you took tamoxifen alone, based on the tumor DNA, this is the chances it could come back if you took just tamoxifen. And we're morphing these figures and trying to see, well, does it only work in small tumors, or does it work in large tumors? Does it work if the lymph nodes are not involved, or does it work when the lymph nodes are involved? And this is the emerging science, but all of these questions is leading us towards a time which we are now in, and hopefully we'll get better, where we can now look at someone with breast cancer as opposed to just looking at their cancer and helping them decide, what are my options and what do we think is the best course of action now. Now that's really the
and so that then allows exactly the conversation around treatment decisions for providers and for patients then kind of melds out of this notion of the standard of care is more individualized, is becoming more individualized over and over again. Precisely. Yeah. Thank you for that. Blakely, I'd love for you to tell us a little bit about your story, and as part of that, to the points we were just talking, would love to kind of hear how you've also been able to make your own treatment decisions alongside Dr. Dizon. So tell us a little bit.
So I found a lump at the beginning of October 2019 while I was getting ready for work one day. It was just a regular day, and I was like, this doesn't, I gotten dressed a lot of days and put on my bra a lot of times, and I was like, this just doesn't seem right. So went to my doctor, wound up with a mammogram and diagnostic ultrasound, and then was diagnosed by the 31st of October. I got very lucky. I was 36. Nobody blinked twice about me being as young as I was. But again, I recognize I got very lucky because that's not everyone's experience. So I live in Rhode Island, and I immediately went to the hospital in Providence where Dr. Dizon works, and met him And I also did decide to get a second opinion just because I am someone who wants as much information as possible. So, and then I, made my choice. I was aware of standard of care. Standard of care is a very obscure word and phrase for most everybody. My background is medical health kind of education. I had that in my background. So I was a little bit familiar with what that meant. And so going in, it wasn't, it was, I'd say a toe up, but that's about it, because I have learned so much since. So, as I mentioned, got a second opinion and, very much learned what my tumor was. I was HER2 positive. I was ERPR positive. But those percentages were very low. So, my tumors were ERPR positive, but less than 10%, which when we start to talk about personalized medicine and personalized choices, all of those details really play in. So, that's my story. I did about 5.5 months of neoadjuvant chemo. So chemo before surgery, which of course, that terrified me because I was like, I thought you're just supposed to get it out of me now, like just surgery first. That's what I understood. But, again, I did, trust the doctors, and they said, well, actually, if we can shrink this a lot, then that's the best thing. And, you really do get an education. So I did that chemo first. My tumor shrunk about 75%. Then I had a lumpectomy. I had surgery about 5 weeks into COVID. So that actually influenced my treatment decisions based on what the hospital would do at the time. And then I, based on the pathology after surgery, I was given the option for, again, it was a recommendation that I decided to go with for adjuvant chemo. So I did 14 months for 14 rounds post surgery and post radiation. So and then I finished active treatment March 2021 and began endocrine therapy, which is another whole aspect of care for hormone positive cancers. So that's a little bit about
and
my background.
Thank you for that. I mean, so many questions that just immediately popped to my mind just going through that. I can tell you my own experience as well, 2019. And just a lot of what you shared is very, very similar to what I was experiencing as myself. At the time, I was a metastatic, so I was already, off and running, as they say. But what's interesting is you mentioned, you had a really good footing, right, a toe up into what is standard of care. I would say that I was probably on the other end of that because there was no history in my family, and I had always had clean mammograms. So I had no idea that this was even possible, and it was already metastatic when it happened. So I'm curious, Dr. Dizan, for patients who do not begin with a baseline of what standard of care, right? So they receive the diagnosis. I'm curious, what are some things that you recommend people try to understand at the point of diagnosis so that informs their treatment decisions? Because I wish there was so much more that I would have known back then. And I had excellent care, and I still do, thank God. But what would you say they need to understand at the beginning of that diagnosis?
I don't think there's anything that they need to understand at the diagnosis, is what I'm going to say. What Blakely taught me is that people learn with time. And what Blakely did, because she needed to understand, and this is not uncommon, I think many people listening have the same experience. She needed me to repeat things. And then she needed to ask why. Why am I going to do this part? And she wasn't shy about it. And I think the difference between someone who doesn't know anything about medicine is coming to this completely cold, like they were never going to go to the doctor until they were 90 with a heart condition. And all of a sudden they're young and they're coming to a doctor with cancer. Blakely, probably you did have that experience in medical health and medical communication. Plus, there were other things. I don't know if you want to
Right. Yeah. Well, and I should clarify that I knew absolutely nothing about breast cancer standard of care, nor did I know anything about standard of care for my specific diagnosis. I understood what the concept of standard of care was. Quite honestly, it was actually from diabetes education. So I had just like, I had heard this word, like this phrase before, standard of
Yeah.
care, you know, and this is kind of like, this is the baseline of what should be happening, you know, at hospitals across the country. But again, you know, throughout this whole process, I live in New England. I'm very close to some of the major, you know, academic teaching hospitals from Brown, you know, which is right down the street from Harvard, which is, you know, close to Mass General. And, you know, then we're close to Yale, New Haven. We really have a lot of education and science going on in this area. And, you know, for that, it really changes. So, and the other piece that Dr. Dizon's referring to probably is that my diagnosis at 36 came about 4 years after my mother's death from ovarian cancer. So I had been a caregiver for her for 3 years during her treatment, and I understood that very well. However, I immediately then thought that, you know, I had the same fate as my mom, who had died 4 years prior. For which he assured me that at that point in time, it was not the case, and it was a very different diagnosis. And so I had a lot of, you know, challenges coming in, just be like, okay, you're not going to die. Like, you're going to be okay. That took a while to kind of wrap my head around, like, okay, this is a different disease. And then in either breast cancer, you know, breast cancer land, as we've already said, there's so many different varieties, and then even varieties within the varieties.
I don't know if you sensed it, Blakely, but I remember when we were going through your receptors, you know, we're like, oh, it is a hormone receptor positive, weakly so, but it was almost like, but it's also HER2 positive. And I think I was a bit excited about that because we had treatments for HER2 positive disease that
Right.
work really, really well. And you know, I've learned from treating folks like Blakely that there is no optimistic news when it comes to cancer, that having a HER2 positive disease is not something to celebrate for someone who's just newly diagnosed. It's good to know that there are treatments for that. But to get to your first question, Amelia, it was sort of it's a process. And what Blakely did was advocate for herself. And she needed to understand why. And she did her own reading. And I fully supported her having a second opinion as well. But she wasn't satisfied with the first go round. And she also wasn't shy, but asking me for clarification. And I think throughout it all, it was a process of, actually, it became like almost two colleagues discussing the data.
Yeah. And that's so important. You know, I think I had to quickly ramp up myself as well, because I came from a background of, you know, of being in corporate America where we were doing high problem solving all the time. And so you kind of walk into this problem that is life and death, and you're trying to all of a sudden kind of amass all that information. And many times you feel ill-equipped, right? And looking back now, I think, oh, these are some of the things that I would have wanted to ask right at the beginning, or at least to have that, you know, readily available that I could grasp. And I think, you know, something that you both said, so I'd like Dr. Dizon for you to kind of start off and then like to provide some perspective, is how do you communicate then with a patient that doesn't necessarily have that strong decision making or advocacy for themselves, because not everyone is in that same, you know, it's a continuum, right? And some patients have less comfort with that. There are many cultural factors that play in, or even just where they are or how they're processing all this information at once. So what are some things, and how do you communicate with a patient that is not as, you know, as driving as let's say we were at the beginning of this?
Well, I mean, I think it's first to understand that people are very different in how they make decisions, and that's okay. You know, I've run into a fair share of people who say, you know, I trust you, I'll do whatever you say. And they really don't want to get into the details of it. They just want to know what the plan is. So my job is not to force them to understand my rationale for it. but is to say, based on everything, this is what I think, and this is why. Well, how do you feel about it? If they say that's fine, let's just do it. I will do one thing on everybody. If they're like, just whatever you say to folks like Blake, is like, I just need you to map this out for me, and I want to digest it, and then I want to talk again. Everybody I meet with gets the same conversation twice. I will tell them everything that I know about their cancer. I'll get to know them. I'll propose a plan. I'll go through the plan. And then I will say, and so I'm going to give you information. You're going to take it home and you're going to show it to people. And then you're going to come back in a week and we're going to have this conversation again. And we're going to start with your questions. With
I
folks
love
like
that.
Blakely,
I love this notion of twice, right?
Yeah.
Because there is, there's a you have to download some of this in your own mind to at least,
100%.
sit with it for a minute.
Yeah.
The challenge sometimes though is the speed at which everything is moving. But I love this point that you're making around let's go through this twice, because I think so often you feel like you have to do it in the moment.
Yeah, and I think it's really important that people know that, if you need that extra week to synthesize it so it makes sense for you, that's not going to be the determining factor of whether you live or die of cancer. Okay.
There you go.
That this
That's
is
a great point.
If it feels like a moving train, ask me if it's okay to stop the brakes, because oftentimes there is time to be thoughtful. And I can say, treating folks like Blakely, who are really good advocates for themselves, reinforce this idea that people oftentimes need information, and then they need to get out of the cancer center and then come back.
Yeah. And that brings me to another point, is the role of the provider, right? The healthcare provider leading versus guiding, or a blend of the two. What would you say, is that primary? Should they be leading? Should they be guiding? How should they be coming at it?
I like advising. I'm going to pop in.
Yeah.
I like advising because that's how, ultimately everybody is in charge of themselves, and everybody should be the boss of themselves and what happens to them. And I am someone who is naturally very outgoing. So that helps. I also I try to make a lot of this a little game, because why not? It makes it more fun when it's actually miserable. I'd be like, okay, let's go try to stump Dr. Dizon. Like, I'm gonna throw him this wild card and like make him work today. Like, he doesn't get to phone it in ever.
No, I don't think he can ever say that I phoned it in with you there. But
No.
No. Yeah.
The other piece is that, I was someone who's like, I want a plan, I want a roadmap, but at diagnosis day, I wanted a roadmap for, the next, what was almost 20 months of treatment. And depending where you are, kind of re-gauging your thinking, and only, taking, one step at a time, which this has been a lot of work. And I've done, a lot of yoga work and a lot of different, complementary things to help, kind of a lot of therapy, to kind of, think about, well, we don't even get to make that decision yet. The first step was, for me, was neoadjuvant chemo. And then you have to recognize that nobody can know necessarily what type of surgery until, you see how effective that chemo was. And then you have surgery and you get pathology results. And then that information informs the next step. So even from the outset, Dr. Dizon couldn't tell me, like, well, how long is this going to take? Because he didn't know. And of course, when I got my pathology results after surgery and I found out I was going to have, I think it was 9 more months of treatment instead of, what I had thought was going to be 6 more months, even though that 3 more months, in hindsight, at that moment, it just sent me absolutely reeling, because I was like, 9 more months. And for me, 9 months was a trigger because I had wanted to have a baby before cancer. It was just, I was like, oh my gosh. So, but definitely really trying to, come up with this mentality that, you are in charge of yourself and this is your life. It's a very a silly comparison, but like when you're, it's different types. If you're at the hairdresser and like you're too afraid to be like, no, I don't like that cut. It's like you have to really, and that's of course that's a hard topic in cancer land, as I like to call it, with hair. But you have to
It
really speak
is.
up because this is important, and nobody cares about you as much as you should care about you. So yeah, that idea of kind of decision points and really trusting yourself. During when I was deciding where to get treatment, whether in Boston or Providence, I asked myself a lot of questions that didn't really have anything to do with care. It was like, how long am I going to have to be in the car? How many days a week am I going to have to go? Am I going to have to, who's going to be able to take me? Like there was a lot of things that I asked myself to see, how well it sat with me. And that was also what informed my decision. It wasn't just like the doctor or just the treatment.
And I think something that you said is also a really important point at the beginning when you were talking about the plan. I'm also very similar. I wanted a plan. And I think what I would say is, for me, my treatments failed for the first 18 months. And it was not because of any gap in care. My care was also prestigious organization, Cleveland Clinic. I mean, just, top notch. And the challenge was it was just not responding. So it kept failing. So I went through 7 lines of treatment in 18 months before we found the one that worked. And in the process of that, it was getting, ridiculously worse. The point that you made around the plan and not setting yourself up for that expectation is because there are nuances that happen. There are failures that could occur. There are, Dr. Dizan, you talked about recurrence or, a change that could happen. Now, suddenly now the treatment has to go a different direction. So I think that it's also very important to give yourself as a patient that grace that things are going to ebb and flow. And that is super, super hard to digest. You both touched on additional pieces like the role of therapy, which I did as well as yoga and other things. Can you touch a little bit also on this notion of how the patient can prepare themselves for what could be failures, because that could happen, sometimes very quickly, sometimes it's okay for a little while, and then a spring pops. So Dr. Dees, I'm curious first from you around the navigation of that, especially the first 6 months of treatment that can be so very tricky.
Well, I mean, I think, and some of the conversations that Blakely we had were only peripherally related to the cancer and its treatments. It was really about how am I supposed to be living through this? It's at some point, and Blakely's not alone in this, but it was terrifying. The first 5-6 months was terrifying. I would see women every time they came in, they were in tears because they worried I was about to say something. It's like it's not working. So there is this fear of progression. There's this fear of recurrence, and it's a very, very real phenomenon. And again, I think this is what we learn from the people we treat. And Blakely has been one of my best teachers, actually. We need to understand that people don't leave their cancers in the cancer center. It follows them. It follows them home. It follows them while they're trying to reincorporate their lives. And if someone is struggling, we need to give voice to that. It's like there is always a chance that things aren't going to go the way as planned, that this map that Blakely you're carrying around with you, there will have to be a stopping point and then maybe even a U-turn, or we'll have to go right when we thought we were going straight, and the journey may get more circuitous, but at least acknowledging that that's true, not providing this, false sense of security that it will all go fine and this is a blip, but you're still on the right path. And then 3 months later, you're dealing with someone whose treatment failed. I was like, well, let's just go on the next one, And not only that, I mean, I think some of the things that we spoke about was just how hard the treatments were. And it was such a thing that we spoke about. It's like, how do I navigate this? Do I have options beyond this horrific thing you have me on? And really, I challenged you, Blakely, a lot about we could stop this.
Right. And that actually has come up the idea I think about, well, stopping it is, so I've been on endocrine therapy, and that is an actual nightmare. For anyone who might be starting it or going through it, you know, some people do really well. I actually did take a break from it. I'm currently on a break from endocrine therapy. I didn't realize how terrible it was until I went on a break, because I had compared it to active treatment, you know, active chemo, and comparatively, endocrine therapy is a lot easier, quote unquote, than you know, active chemo, where, you know, I had lost all my hair. I was, you know, nauseous constantly. So not being nauseous constantly and having my hair grow back, those were two huge pluses. However, there's a certain level of misery that is constant. And so this idea of choices, and I have spent a lot of time thinking about what's in my control versus not in my control, and, you know, what can I choose? And I'm talking, you know, everything from alcohol to whether or not it's fine to eat cheese, you know, because I was hormones receptor positive, and depending on what you want to read and believe, you know, that's something in my choice. And so it's like I have control over whether or not I, you know, drink alcohol also, and or whether or not I eat cheese, and which seems silly, but I know it's a thing. And, you know, I just had to kind of really think about what's going to be best for me. And then there's this something that we, you know, talk about is, you know, what is your appetite for risk? Because with this idea of endocrine therapy, especially, you know, I could say no. Like, I could say, I absolutely don't want to do it. I feel so much better off of it. However, you know, I do very much view all of my doctors as extremely highly educated consultants. And they are there, like, based on what we know, like, this is what we recommend. And then, you know, Dr. Dizon was extremely good at being like, and it's your choice. And then, you know, really kind of wrapping your head around that and kind of putting yourself in this mentality. It's like, I am in charge of what happens, and I can choose to not do it. You know, there was a point after I had started endocrine therapy where I needed to make a change. I actually went to the doctors in Boston. I got their opinion, and they said, you know, I did, so for reference, I did Lupron injections monthly, and then I started with the L1.
Letrozole.
Thank you, letrozole. I was like, which I was gonna say some other L, I can't. Yeah, letrozole, and it was terrible. And you know, Boston had said, oh well, we would just put you straight on tamoxifen. And you know, Dr. Dizon was like, well, you could go straight on tamoxifen, or you could try a different AI. You know, so I quite literally took the side effects of tamoxifen and Arimidex, which is what I wound up taking. I read the side effects, and I saw that, and I compared the side effects. And I was like, I'd like to try Arimidex before I go to tamoxifen. So that's what I did. And, you know, that was where I felt comfortable. And that was the kind of decision I made. But this
And
notion
it is
of,
an important point that you're driving here, because I did the same with my own treatment. It's this notion of balancing risk, and how risk balancing allows you to make choices. Because I think what happens all too often, and I've lived this experience, I've also, you know, known, like you, many other folks in it as well, is there is a standard protocol practice associated with whichever medication treatment path you are, you know, best prescribed to take. But the side of that is all the other adverse pieces that come with it. And so, and it isn't as though that prescribed path is a 100% guarantee, to the point that you made earlier, Dr. Dizon. There's no guarantee on one end, there's no guarantee on the other end. So you have to kind of live, you know, in this, you know, navigation mode. But the ability to balance the risk with making choices is an important piece that I think that I'm so happy to hear you convey to this audience group. I've done the same. We've made, my doctors and I, adjustments to my treatment cadence to manage those side effect components, because quality of life is an important piece. And also, the adverse effects, what I call, compounded interest the wrong way. There's so much that is happening to the body as well. So you're trying to balance those two pieces. And I think it comes down to weighing the risks of here's what it means and here's how I'm living my life day to day versus these other pieces that I can do to try to stretch it a little bit more. Right.
But
And to kind
importantly,
of,
I think the more important thing is that the person who needs to make those determinations about risk and side effects and benefits and all that, it's not me.
it's the patient.
Yeah. Blakely took she did. She read on everything and said, I would prefer to do this. And I was like, okay, that's what we'll do.
And that is,
and the piece that I think that some folks are also, in the Q&A is coming up is that there are some, there's some patients whose doctors are not able to, are not as open as you are, Dr. Dizon, to the role of the patient as also a co-navigator. Or they don't have the access or are not as connected to the latest things that may be available. And so I think how does a patient navigate that piece, right? I think I'm a fan of second opinions. I got them as well at the beginning, and I've gotten them even at junctures during my treatment when we were thinking of making adjustments. But that was also encouraged by my doctor. They wanted another set of eyes. They welcomed that. But some of the comments that we're getting is, what if I'm with a doctor that doesn't, that isn't able to answer my questions, that doesn't necessarily know those things? What path can I take, or should I take as the patient?
Well, I mean, I think, a conversation I have with pretty much everybody is as well that, I work for you. I work for the people that I'm treating. It's not the other way around. So I'm oftentimes really trying to assuage concerns when people leave my practice or when people go for a second opinion, decide to stay at a different institution. You are well within the rights to get the care that you need with the person who you best identify with. I think it is harder in a more rural community or in a smaller city where there's really one medical practice and they all belong to the same practice. And then there are the intricacies of, well, I don't want to piss off Dr. X, so I can't take you on. I think feeling stuck like that is a very big dilemma. And I think what Blakely can teach everybody is even in scenarios where you don't have the choice of a provider, you can still expect them to do more for you. And I think that's really what Blakely, it's all our communication style has gone to the point where I anticipate that not only is she going to want to know what did I learn from the last meeting I went to, and this decision to go on a break was certainly, I mean, we were communicating via Instagram with each other as some of this data came out. But I know that she's following the literature as well as I. And I can expect those conversations when we meet. And I think at some point, my hope is that people and their relationship with their doctors does morph into something beyond doctor-patient, where, relationships develop, and I think that's the best of both worlds. But for anyone who's stuck and embarrassed that they can't upset their doc or stuck with a doc who is not listening to them, it's okay to say to yourself, I actually deserve better than this. Yeah.
And there are, I don't know, very recently, but I know that a lot of the major cancer institutes do offer, virtual second opinions. So if you are somewhere where you don't have access to a major cancer center, and this isn't something that I've looked at recently, but Dana-Farber is where I went, because also Mass General is in Boston, but Dana-Farber is where my mother had gotten treatment. So that's also where I went for the second opinion. And I know at that point in time, they did offer virtual second opinions. So even if you're somewhere else in the country and you would like, them to review your case, then, that's something to look into. I will I'll also say that I got, at the very beginning of my diagnosis, I got 3 different options. So for treatment for neoadjuvant chemo, Dana-Farber said, well, these are the 2 different things that we could do. And then, I call it Dizon's delight. I got it at home. I'm like, he's mixing up my chemo cocktail, and it was slightly different. It wasn't exactly the same. It was based on a different study. And, but, I collected enough information at that point in time. And now we're talking, within a couple of weeks of diagnosis. So like, we're talking, I found a lump the first week in October. This was, the first week in November. So this was very early on. Because at some point, I do like to think about what's in my control and what can I do, and this is my decision. But then there are definitely points where I'm just like, the heck with it. I'm just going with what they say because it's too much. I don't have the energy to fight or care. I mean, I cared, but I was like, I don't have the energy to read another thing. And I didn't Google a lot. I would, I was like I looked at very little bits. I would reference the studies that, Dr. Dizon or, other doctors were talking about, and I'd be like, yeah, sounds good. And that was good enough for me.
Yeah.
Sorry, I'll just add that I keep referencing this break. So it's important to add that the literature, the study that I'm doing this break based on is the positive study. And it's a maybe baby break for me right now, because again, and I decided to take a break because prior to treatment, I had wanted to have a baby. And that was, I think I actually mentioned it in my bio, because before I did any of this, I actually did fertility preservation. So the study that I'm throwing my life, I'm resting my life on right now, is the positive study, which Dr. Dizon that's it. That's what it's called. So.
Yeah, I mean, it was a huge breakthrough for us, right, at the breast cancer community, because it actually put figures down for women with its hormone positive breast cancer who decide to stop endocrine therapy so they can try to get pregnant. And it wasn't a randomized trial or anything, so we don't have a figure, but the risks were not that high. And again, Blakely and I reviewed it, and we made decisions, and she made decisions about this falls into the risk that I'm comfortable with to achieve this goal that I've always wanted for myself, But
I also don't think about it that much. It's like I make a decision, I'm like, that's the decision you made.
It took you a while to get there, but you did make that
decision. It did,
but
it's been almost 5 years. Like, I can say that the amount of, practice I have had to do, just be like, this is the decision you made. You can you can make a different choice. But this idea of the plan, like, I really wanted an absolute roadmap at the beginning. And I had to recognize that it's not realistic, because you never know.
Right. And you have to be able to let go. Right. And I think that
Exactly.
was really, really difficult for me, because, similar personality, very much of, okay, we've got to have a plan. We've got to understand these pieces. There are a couple of points that I want to underscore for those, because I think the points that you've made have been so incredible. One is this notion also of virtual second opinions. I don't want to lose that, because that's something I also did. And it was immensely, immensely helpful, because it's a way to have access and to reach. We did with Dana-Farber, with MD Anderson, and so you have a chance then to get to other doctors that you may not have available in your own little zip code of the world. The other piece that I think is important also is this notion of risk assessments, and we've had some questions on, are there some risk assessment information out there or protocols out there that I can use as I'm navigating through this. Sometimes I think it's what you said, Blakely. It's like, just go. I'm letting go, and I'm going to see what happens. But I think there's also, to the extent that there are some questions that help patients understand how to assess risk. For me, it was intuitive. I started to think through side effect management, how we were doing with the scanning. So I started to layer in the data that I was collecting for myself, and I used that as my risk assessment protocol. But are there some other things that Dr. Dizon, either you know of or things that you tried that helped inform your risk assessment? I think it's an excellent question on the Q&A chat that just came through. Yeah.
Yeah, I think because breast cancer is so different now, that I think the risks, hard to generalize about risks and benefits. That's going to work for everyone's kind of breast cancer. I think practically speaking, it's not only important that I tell you my impressions of a drug, but that I actually hand you information, really hard information that says, this is what this drug is, and this is the reported side effect profile. So I told you stuff. Here's some things to look at as well. This is option B. I can tell you this, and here's some information on that. And if there's an option C, give you that stuff as well as information, and then give you time to process that, and then come back. Because I think, what it's what Blakely taught me, is that people will actually look at that. This is not something that's like, okay, my doctor gave me stuff and I'm just going to put it in a drawer and never look at it. If your life is depending on it, you're going to look at it, and you're going to see things that say, I am not able to accept the risk of uterine cancer with this drug. I'm just not. So I would be, I think Blakely was like, it doesn't happen to young women. It's a really rare side effect, and these are the risk factors. But at the same time, you're the one that had drug, and
that was the deciding factor for me on the decision of tamoxifen versus trying a different AI. For me, reading that uterine cancer could potentially be a side effect of tamoxifen, I'm like, nope, not doing it.
Yeah,
I'm going to deal with the AI, and just that was my choice. Tamoxifen, I might do much better on tamoxifen. The side effects of endocrine therapy that I experienced were fairly extreme, to the point it impacted my relationships, with my husband, like I think Dr. Dizon has, a sexual health clinic written about in his, that's on his bio, another part of it, every aspect of my life. There's a lot of acceptance that has to go into it. I hated the idea of taking, an anti-anxiety medication to counteract the endocrine therapy. I hated it. I'm like, I hate this. I hate it. And I'm going to do it anyway, because I found out that worked really well for me. And I felt a ton better. It didn't make everything go away, but it made things more bearable. And that's like,
what would you say the role of priority setting within your life kind of played into some of those decisions? Because I feel like depending on where someone is in their life, right? And I think sometimes we don't think about that intuitively. Like you clearly did. You had priorities that you put into your decision. How did you kind of make that happen?
How do you
prioritize, like the role of priorities?
What is the most important for me? One thing that I really kind of have thought about a lot is that I really worked a lot on acceptance, and I kind of sunk into it, which sounds, I didn't fight against the fact I had cancer. And a lot of that actually is because my mother, when she was going through treatment, she really had this battle mentality, and she's like, I'm going to beat it. I'm going to, this really, my mom had a massive debulking, a 12-hour debulking surgery for, basically stage 4 ovarian cancer. And she decided to walk a 3-mile walk for Dana-Farber, fundraising for Dana-Farber, 3 weeks after she had the surgery, because she was so damn determined. But my experience was, I was like, well, that didn't necessarily turn out for her very well. So my approach to treatment was to just accept it. And if anything, I probably didn't, mush into the couch as much as I should have. I was in a position where I could take a leave of absence from work. And I did. I took a few months off during the worst of treatment, and I just had time to just be with it and sit, a lot of hours by myself, sitting on the couch, and really kind of thinking about what's important to me. And And, that was what I wanted to do. And that felt right for me, just accepting like, this is where you are and you're going to go through it, and you're going to feel your way through it, like based on your gut. So it's definitely kind of something that I just really had, but that was a lot of work. I'm almost 5 years out from diagnosis. I had 4 different therapists that I talked to regularly during active treatment. I talked to the chaplain at the hospital, like practically every time I was there. I had a couple therapists that I talked to sometimes. I had my own personal therapist. I had a different, I tried different things. Like I spent a lot of time just like navigating this, because it is an absolute nightmare. I mean, it's a nightmare.
It is.
Yeah.
We can make it as light as we want to, but it is an absolute nightmare, and it sucks.
Yeah.
Absolutely sucks. The toxic positivity bullshit. I'm like,
yeah,
this.
I am right there with you. I am right there with you. And I think that the word that you said that's so critical is acceptance. And I think that acceptance does not mean defeat. And
Right.
acceptance is not a weakness. Acceptance is the ability to actually come to grip with what the reality is in that moment, knowing that the reality is going to change. And sometimes that reality can become bad for a little bit or for a long bit, or it can become really good for a while. And so, but I think if you're constantly bracing for impact, your body's going to take a lot more of a hit, and because you're constantly in this, brace impact, as opposed to, all right, I have to kind of accept it and then navigate through it. I think I took a very similar approach early on.
Sorry to interrupt. There's a book called Radical Acceptance. I haven't read it. I like to read like the highlights. Like I want to read an intro. I might sound like I come across like I've read every single study. I read like the abstract. So I read like 3 paragraphs. That's enough for me. And then I make my decision. The book Radical Acceptance, I've never actually read it. The title was enough. I just have got to that. Like, I'm like, okay, this is happening. And so what are we going to do about it? And it sucks. And, I did a brief foray into improv comedy in the past couple of years. And they say yes, and, so there's no wrong answer. It's not a but situation. It's yes, I have cancer. And what are we going to do about this? And how are we going to move forward? And what can I do to make the best of it?
I love it, because it is exactly that. It's a point in time, and that's all we can get to one at a time, as I say. I want to we're getting to the end of our hour here. This is such a rich discussion. We could go on, I know, for forever. I know I could. I'd love for any final thoughts, any other comments or things that we didn't get to touch on that you really want to convey to the audience. I know we only have a few minutes left, but I'd like to at least, give you a chance. Any other thoughts or comments?
I would just say that I think, remembering that this is your life we're talking about, going in with that strength, and not even worrying about if your question is stupid or simple or not appropriate. If you have a question, you have to ask it. And if you are afraid of something, and Blakely, you did this so well for me. If you're afraid of something, say it. At some points it was like, oh, I have this pain, blah, 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 blah. And I was like, okay, well, watch it. Blakely would be like, I don't feel right. And I think I'm worried about a recurrence. And it totally took the conversation a different way. We can't read your minds as your docs, but we can certainly help put you at ease, in case it's something serious that you were worried about. So that kind of honesty I think it does take some strength, but at the end of the day, we work for you. So you need to tell us what we need to do to help.
I love that you say that. That is an excellent. It makes it changes the patient role to the customer, right? The patient as a customer, as opposed to the patient as some other individual. Blakely, any other closing thoughts before we wrap up?
Yes, I would just say really do advocate for yourself, because it is your life, and you have one life, and it is it is kind of easy for me to say because I'm a very loud, outgoing person to begin with. However, whatever any individual person can do to like search deep down inside to be like, just take charge. You are the boss of what happens, and really just kind of own that, and trust yourself. If you
Yeah.
have a
Yeah.
concern, bring it up, because
Yeah.
there's a lot to be said for, gut instinct. So that's what I.
Absolutely. Well, very well said. And I can't thank you enough, both personally as a patient in this journey, as well as the moderator for today, and on behalf of LBBC. And just thank you so much for this phenomenal conversation and for your candor and your openness.